Good evening. Our fall 2007 lecture series begins with tonight's discussion, the first of a two-part presentation on optimizing patient outcome in patients with congestive heart failure or individuals who have sustained a heart attack, a myocardial infarction. Tonight we'll talk about drug and device-based approaches. Next week we'll talk about nutritional and complementary approaches to heart failure and post-heart attack outcome. My name is James Roberts. I'm board certified in internal medicine and in cardiology. I've been practicing invasive and integrative cardiology in Northwest Ohio for the past 21 years. And I'm the medical director of comprehensive heart care, the EECP Center of Northwest Ohio, and the Advanced Magnetic Research Institute of Northwest Ohio. And along with my colleagues Stephen Sinatra and Marty Zucker, I'm the co-author of Reverse Heart Disease Now, a patient manual of integrative cardiology. Reverse Heart Disease Now focuses on coronary disease. The topics that we're going to discuss tonight and next week will be the foundation for a companion book, Reverse Heart Failure Now. Our discussion on dealing with heart failure and heart attack is based upon our understanding of the pathophysiology of these conditions. What are the causes of heart failure and heart attack, and what are the physiologic consequences of heart failure and heart attack? If we understand these mechanisms, we can do a better job constructing therapies to improve your outcome. My approach to the patient with heart failure: symptom control, volume removal with diuretics, with careful attention to potassium, magnesium, thiamine. We need to get rid of your excessive fluid without causing an electrolyte deficiency. Tissue-specific ACE inhibitors, which block vasoconstriction and inflammation, watching for low blood pressure or kidney compromise. And I want to leave room for spironolactone, a drug that blocks the sodium retention and inflammation due to aldosterone. And I have to watch to make sure your potassium doesn't go up or that I don't compromise your kidney. I'm going to block the adrenaline whip with Carvedilol, Coreg, or Metoprolol, watching to make sure I don't lower your heart rate and blood pressure too much and make you fatigued. I may use pentoxifylline and low-dose statin therapy for their anti-inflammatory effects, blocking tumor necrosis factor alpha and free radical generation. I might utilize an external counterpulsation or dual chamber pacemaker in placement. And in selected patients, we may also use magnetic molecular energizer therapy. That's the drug and device approach. For all my patients with heart failure or coronary disease or prior heart attack, we'll also make some nutritional recommendations: a broad spectrum 6-a-day vitamin and mineral supplement, fish oil for everyone, CoQ10, carnitine, ribose, magnesium to help you make ATP energy, taurine to upregulate the enzymes that make nitric oxide, vitamin D if your levels are low, testosterone and men if your levels are low, and then detoxification using chelation, homeopathy, the ionator foot bath, far infrared sauna, or MME. The integrative approach to congestive heart failure involves bioenergetic support. We need to quell inflammation and oxidation, improve the endothelium, and promote detoxification. The modern day drug approach to congestive heart failure involves neurohumoral blockade. Let's consider how the body responds to the condition of congestive heart failure. No matter what the cause of congestive heart failure, all CHF is characterized by reduced forward blood flow. The heart is not pumping enough blood into the arterial circuit to meet the needs of the internal organs or the muscles. And they don't like it. We have blood pressure receptors in our arteries that can sense the subadequate blood flow. They feed back to the autonomic nervous system that cries foul. So the autonomic nervous system releases noradrenaline and adrenaline to whip the heart because the body wants the heart to function better and to constrict the blood vessels so our blood pressure will rise. There's not enough blood flow to the kidney or the adrenal gland, and they release hormones that lead to fluid retention because all they're thinking about is themselves. They're not thinking about the heart. The kidney, the adrenal gland, the arterial circuit, they want more blood, so they want to whip the heart to meet their needs. And these whips will damage the heart, cause the heart cells to commit suicide, called apoptosis. So the body's response to congestive heart failure is totally maladaptive. And we have to block that. But then you might ask, why did Mother Nature develop this maladaptive response? Mother Nature is not stupid. She doesn't make mistakes like this. And she doesn't. But we have to remember that our physiology was designed 1,000,000 years ago. And we are going to respond to congestive heart failure the same way a caveman would. And we have to ask, what are the circumstances in which forward blood flow to the kidney, the adrenal gland, would be compromised for a caveman? You know, heart disease is only 500 years old. People did not have coronary disease 500 years ago, and they didn't have congestive heart failure. These are new diseases, and evolution has not caught on. But if you were a caveman, what would be the circumstances in which forward blood flow to the kidneys, to the arteries, to the adrenal gland would be low? Well, maybe if you were dehydrated, or if you were bleeding to death, or if you were septic, if you were inflamed. Those would be causes of low blood flow. So it makes sense then to make adrenaline and drugs and hormones like that retain sodium and water and constrict our blood vessels, because they would allow you to survive until you quell the infection or until you got some more water. So we have to understand that the body's response to congestive heart failure, poor forward blood flow, is maladaptive today, but it was physiologic in the past. But we're dealing with you in the here and now, so we need to understand this maladaptive response and block it. And that's the concept of neurohumoral blockade. Now, when we treat patients with congestive heart failure nutritionally, we'll talk about these approaches next week. CoQ10, carnitine, ribose, taurine, antioxidants, fish oil, arginine, testosterone, vitamin D, chelation therapy, which we're researching right now. Tonight we'll talk about drug approaches and device approaches: digoxin, diuretics, ACE inhibitors, aldosterone blockers, beta blockers, pentoxifylline statins, external counterpulsation, far infrared sauna, dual chamber pacemaker implantation, and MME, magnetic molecular energizer therapy. Whenever we're treating a patient with heart failure or any heart disease, if we can, we want to improve endothelial function. We want to encourage the endothelial cells that line our arteries to convert arginine to nitric oxide. We want to make a lot of nitric oxide. We don't want to make superoxide, the free radical. If we can block this enzyme, angiotensin converting enzyme, we can block angiotensin II, which is a vasoconstrictive free radical. We want to preserve bradykinin, some of the good guys. So we want to pay attention to physiology. We want to make a lot of ATP. ATP is the only source of energy that our cells can use to carry out useful work. The struggle for survival is the struggle to make and regenerate ATP. We need a high level of ATP in our cells. The heart needs ATP not just to contract, to relax, but to contract, relax, while repairing itself and pumping oxygen in and sodium out and potassium, etc. We need lots of ATP. How are we going to treat congestive heart failure? The classic approach is the way I was trained when I was an intern at the University of Cincinnati about 26 years ago. Back then, the 1-year mortality of patients with congestive heart failure was 50%. That is if they stayed away from us. If they let us take care of them, I think they did a little bit worse. Because all we had back then was digitalis and diuretics. And we just had these two hammers, and we would hammer pretty hard because that's all we had. Now, our analysis of heart failure back then was the problem was pump dysfunction. The heart pump is poor, not pump enough blood, so we're fatigued, and the drug we would use is digitalis. Digitalis, we felt, it's an inotropic agent. It'll cause the flagging heart to squeeze a little bit better. And it does. It will improve pump function, it'll improve your ejection fraction, and you'll get better. The problem is it has a very narrow therapeutic index. If we give you too much digitalis, it can cause a lethal cardiac arrhythmia, especially if you had low potassium or low magnesium. And we would push the digitalis dose because it's all we had. And we would see these patients at the hospital, we would digitalize them, they would get better, and then they wouldn't come back to the clinic because they died suddenly at home. So it's it's all we had. When I was entering private practice about 20 years ago, we came up with digitalis antibodies. We would give you too much digitalis, you would come into the emergency with a heart rate of 25, ready to die. We would inject a digitalis antibody that would bind it, and you would sit up and you'd be fine immediately. So this is a useful drug, but it's a relatively dangerous drug, and it was all we had before. Excessive preload, the heart will retain fluid. Fluid will build up behind the heart. You'll have shortness of breath from fluid in your lungs or ankle swelling. So we would give you diuretic therapy to mobilize that fluid. And that's all we had, digitalis and diuretics. Now, we have modern day drugs today, neurohumoral blockade. Is there still a role for digitalis? The younger cardiologists say no one should ever receive digitalis, it's too toxic. The older doctors who were skilled in the use of digitalis say, yes, we should still be using it. You know, is it worthwhile to use digitalis in the modern day? So this study was done called the DIG study, Digitalis Investigation Group. We're going to look at 6,700 patients with clinical findings of CHF, congestive heart failure. Their ejection fraction had to be below 45%, on average it was 28%. The ejection fraction is the percentage of blood the heart ejects with each beat. If your heart fills with 100 cc's of blood and it ejects 50 cc's, that's normal, that's an ejection fraction of 50%. These people all had poor pump function. Their heart rhythm was normal, and most of them were on modern day drug therapy. 94% on ACE inhibitors, 75% had been on digoxin, 82% had been on diuretics. So they're getting modern day drug therapy, and the question is, does digoxin add to that or not? So in the protocol, the patients were randomized to receive a placebo every day or digoxin, and there was a weight-based dose, and they tried to get the level between 0.5 and 2.0. 70% got the standard dose of 0.25 milligrams. Otherwise, it's the same care. All the other drugs are the same doctors, same nurses, and you're looking at long-term follow-up. And it was a double-blind study. That means neither the researchers nor the patients knew are they getting placebo or the digoxin. And the study was stopped at 37 months, and they found that digoxin had no effect on death rate. Death rate was 35% in both groups, no difference. But if we look at death due to congestive heart failure, there was a 12% reduction. Cardiovascular hospitalization was decreased by 13%. Hospitalization for heart failure, 28%. Total hospitalization by 6%. There was more digitalis toxicity in the treatment group, as you would expect. So there was no reduction in mortality, but hospitalization due to heart failure, there was a benefit. So the conclusion was that digoxin, digitalis, does have a benefit. Not with respect to mortality, but with functional status and keeping out of the hospital. And digitalis cost only $8 a month. So there is a benefit from this drug, and we will use it. But we will use it carefully. When they reanalyzed the data, and they looked at outcome in relation to their digoxin blood level at 4 weeks, they found something very interesting. The mortality rate was 35% for placebo and all comers on digoxin, but those that had a low digoxin blood level of 0.5 to 0.8 had a 30% mortality. Those that had higher blood levels, even though they were, quote, therapeutic, had a greater mortality and need for hospitalization. So with digoxin, a little dab will do you. We now think that digoxin doesn't really work by making the heart pump stronger, but by altering the baroreceptor response, such that when there's poor flow, the autonomic nervous system does not release as much adrenaline nor noradrenaline. So the message is, we will use digoxin in heart failure. We want to give you a very, very low dose. Then we get the benefits without the downsides. If your potassium or magnesium are low, you're at greater risk for digitalis toxicity. So we want to give you a very, very low dose. And why would your potassium and magnesium be low? Because we give you too much diuretic therapy. When you have congestive heart failure, the congestion is fluid building up behind the heart. The heart's not pumping it out well, it's stiff. It backs up into your lungs. We hear crackles in your lungs and you're short of breath. It can back up behind the right heart and you have ankle swelling. So to improve your symptoms, we're going to give you diuretics, drugs such as furosemide that act at the level of the kidney to cause the kidney to mobilize sodium, chloride, and water. Now, the reason we retain fluid is the autonomic nervous system, the kidney, the adrenal gland, they want more blood. And they want to help the heart provide them with more blood. So they release these chemicals that cause fluid retention. They think that if there's more blood volume, the blood pressure will rise and they will receive what they want. And they will, but the consequence is you have the fluid retention. So it's our job to give you diuretics to mobilize this fluid so you feel better. Now, when I was an intern, we would be very cautious and undertreat you with diuretics. We were afraid then that we would make you collapse and crash. My daughter's a freshman in medical school right now, and she's learning what's called the Frank-Starling Curve. That means that when the heart is enlarging, it's a little bit stronger in contractility. The fibers have a mechanical advantage with their ratcheting. So we felt that when the heart was dilated in congestive heart failure, if we would lower your blood volume quickly, if we would diurese you, your cardiac output would falter and you would crash. We were all wrong. Many of the things we learned were wrong. We're learning now that when the heart is dilated and distended from congestive heart failure, it doesn't pump so well. So now we're more aggressive with diuretic therapy. But those of you who are physicians, remember when you were in training, we were taught to be very gingerly with the diuretics because of the Frank-Starling curve. So now we're more aggressive with diuretic therapy, but I want to give you enough to get rid of your shortness of breath. I want to get rid of your ankle swelling. But if I give you too much, your blood pressure will be fall and you'll stand up and pass out and hit your head, or I'll dry you out so much that I'll compromise your kidneys. So how much diuretic should I give you? This is very, very tricky. We can assess your volume status, your need for diuretics from your physical exam, but we're not very good at that. You'd think we would be very good at that, you know, that I can listen to, if you come in with shortness of breath, is it your lungs or is it your heart? Well, I can listen to your lungs for crackles. I can look at your neck veins and see if they're distended or not. I can look at your ankles for swelling and make my diagnosis, are you in heart failure or not? Study was done, took 100 people, and they did heart catheterizations and actually measured the blood pressure in the heart, which is an accurate assessment of whether you're in heart failure. Then these people were evaluated by seasoned cardiologists like myself, primary care physicians, and medical students. And the question was, could you get it right? Were they in heart failure or not? The medical students got it right 50% of the time. The primary care doctors got it right 50% of the time. And the cardiologists got it right 50% of the time. Which means we're not very good at making the diagnosis of heart failure from physical exam. So we need a little bit of help from the laboratory. BNP is B-type natriuretic peptide, which is quite helpful. This is a protein made by the heart under strain. If the heart is stiff, you make some of it. If the heart is failing and stressed, you make a lot more of it. If you come into the hospital with shortness of breath and your BNP is below 100, it is highly unlikely that you're in heart failure. If it's above 500, you're in heart failure. Between 100 and 500 is a little bit of a gray zone. If you've had a heart attack and you have compensated heart failure, but your heart's under chronic strain, your normal BNP may be 250. So what we're doing is we're measuring your BNP at various times so I know what your BNP is when you're well compensated. But if you have a very, very bad heart and your BNP is down to 50, that means you're dehydrated. So we're utilizing the BNP, matching it up to the patient, using that to help decide, do you need more diuretic or not? We can also do a right heart catheterization. Here we put a catheter into the femoral vein in the groin, advanced under X-ray guidance into the right heart, into the lungs, and I can measure the blood pressure in your heart and know for sure whether you're in heart failure or not. That takes me 5 minutes. I've done this at least 1,000 times. I've never hurt anybody. because we're in the veins, not the arteries, so it's a very low-risk procedure. And often if I can't tell, are you wet or not, and I need this information to optimize therapy, we can do an outpatient right heart catheterization, and that will guide me. So this is how we decide how much diuretic to give you. Now, the benefits of diuretic therapy, they don't block the neurohumeral whips. The diuretics are just really for symptomatic control. Now, no one has ever done a study showing a mortality benefit, and no one ever should, because it's just intuitive. We have to get rid of your fluid if you have congestive heart failure. All the new fancy patentable drugs that we'll talk about tonight, they're wonderful and they're very useful, but in all the studies documenting their benefits, it was on a background of diuretic therapy. So we always start with a diuretic in the patient with congestive heart failure, and they're very inexpensive. Furosemide, the standard diuretic, costs only $8 a month. Now, digoxin and diuretics were all we had, and the one-year mortality was 50%. The neurohumeral blockade, modern-day drug therapy, has a benefit. Adding angiotensin-converting enzyme inhibitors reduced one-year mortality to 36%. Adding in spironolactone reduces to 18%. Adding in beta blockers down to 12%. So in 20 years, we've gone from a one-year mortality of 52% down to 12%. And of course, if we add in nutritional therapies, we'll do much better. Beta blockers. Okay, the heart is not pumping enough blood to meet the needs of the autonomic nervous system. So the autonomic nervous system releases adrenaline and noradrenaline to whip the heart into better performance. Because the autonomic nervous system's not worried about the health of the heart. It wants to use the heart to increase blood flow to the body. Now, these hormones, adrenaline and noradrenaline, can activate beta and alpha receptors, different whip mediators. The beta-1 receptors and the beta-2 receptors make the heart work harder. The beta-1 receptor, though, causes the heart cells to commit suicide, called apoptosis. The alpha receptors constrict our blood vessels. In the kidney, the alpha-1 and the beta-1 activate the renin, aldosterone, angiotensin system, which we'll talk about later on. So we're going to use drugs to block these receptors, to block the adrenaline and noradrenaline whip. Which drugs do we use? We have many different types of beta blockers. The classic beta blocker, the first one that came out about 30 years ago, was propranolol. It will block the beta-1 receptor. That's good. That's the one that causes the heart cells to commit suicide. It'll block the beta-2 receptor. That's bad. That's the one that causes the heart to function well. It doesn't block the alpha receptor, so you don't vasodilate. It doesn't have any antioxidant protection. It doesn't block cell suicide. An improvement is metoprolol. The trade name for that is Toprol or Lopressor. It blocks the beta-1 receptor, but it doesn't block the beta-2 receptor. So you block cell suicide without compromising cardiac output. Also, our airways have beta-2 receptors. And if you have asthma, and I give you propranolol, I'm going to make you wheeze, but not with metoprolol. So metoprolol has a clear advantage over propranolol, and it also blocks cell suicide. The newest drug, Coreg is the trade name for Carvedilol, is biochemically superior. It blocks the beta-1 receptor, it blocks the beta-2, which isn't really desirable, but it blocks the alpha, so there's less vasoconstriction. So you block the beta receptors and you vasodilate. It has an antioxidant effect and it blocks cell suicide. So you would think that Carvedilol would be the superior beta blocker. Let's examine that. Study of Carvedilol, which is patentable and expensive, versus metoprolol, which is no longer patentable, not expensive. So we have to prove that the new drug is more effective. 150 patients with New York Heart Association, functional class 2 to 4 heart failure. Class 1 is you can do almost anything you want. Class 4 is symptoms at rest. Class 3 is symptoms within 2 blocks. Class 2 is you can go more than 2 blocks before you get short of breath. Their ejection fraction on average is 21%. They're on drug therapy. ACE inhibitors 94%, digoxin 75%, diuretics 82%. You do a baseline assessment, then randomize them to receive either metoprolol or Coreg. The metoprolol group starts at 5 milligrams twice a day. You try to get yourself up to 100 twice a day. on average, they got 124 milligrams. With Coreg, they got 49 milligrams. Otherwise, same care. The other drugs were not changed, randomized double-blind study, so there could be no bias. And they followed them for a little bit over a year, and they found that the ejection fraction rose in both groups. The heart pump function improved with both groups. And the Carvedilol group did a little bit better, 12% and 7% from Metoprolol. The end diastolic volume and the end systolic volume fell. Diastole is when the heart's at rest. Systole is when it's done contracting. You want to see those volumes decrease. The heart shrunk. That's a good sign. Both drugs were effective, but the Carvedilol did a little bit better. So here the Carvedilol is looking like it's a better drug than the Metoprolol. In terms of hemodynamics, such as the filling pressure within the heart, which you want it to be low, a high filling pressure will make you short of breath. It means the heart is stiff and not pumping well. You want to see a low filling pressure at rest or with exercise. That fell in both groups. The Carvedilol did a little bit better. In terms of how far you could walk in 6 minutes, the Metoprolol did a little bit better. In terms of functional class, they were about the same. So biochemically and by your echo study, the Carvedilol was better. In terms of how people feel, they were about the same. So this is not a big victory for Carvedilol. Here's another study, Carvedilol versus Metoprolol. 300 consecutive patients with dilated cardiomyopathies not due to coronary disease. They had punk hearts. Their ejection fraction is 40%. Their oxygen consumption is low. That's a measure of your fitness. And they were still having symptoms of heart failure despite being treated with Metoprolol, an ACE inhibitor, digoxin, diuretics. So in this group, Metoprolol alone was not getting the job done. You randomized them to staying on the Metoprolol or converting them from Metoprolol to the new Carvedilol or Coreg. You reassess at 1 year later. And what you find, those that were not doing so well on Metoprolol continued to decrease. Their ejection fraction fell slightly, but that decline was reversed with Carvedilol. So the Carvedilol improved their ejection fraction in these people who were going downhill on the Metoprolol. The same thing with their end diastolic volume. It decreased with Carvedilol. It did not. It actually worsened on Metoprolol. So in people with cardiomyopathy who are failing on Metoprolol, switching to the new Coreg is a good idea. Another study was done with people who were doing well on Metoprolol, and switching them to Carvedilol didn't make them any better. But if you're failing on the low-cost Metoprolol, switching to Carvedilol makes sense. So the evidence here that everybody ought to be on Carvedilol is not that strong. But the drug companies really want you to use this drug because they can make a lot of money. So they're going to keep doing studies till they get one that shows that their new drug is the best. So now we have the COMET study, 3,000 patients in Europe and North America with advanced heart failure, could be due to coronary disease or non-coronary cardiomyopathy. Prior admission with heart failure, average ejection fraction 26%. They're all on standard drug therapy. You do a baseline assessment, then randomize them to Metoprolol or the Coreg. Otherwise the same care. Other drugs are not changed. Mean follow-up over 58 months. This was a multi-center, multi-country, double-blind protocol. A lot of different doctors were involved and got paid by the drug companies to participate in this study. And there was a benefit. The mortality rate with Metoprolol was 40%. With Carvedilol or Coreg, it was 34%. The mortality benefit was seen in all patient subcategories. So there was a benefit. Now, if we just look at mortality and hospitalization, there was no difference. About 75% for both groups. 32% in both groups had to stop because of poor tolerance. An equal number of patients underwent cardiac transplantation. But yearly mortality, there was a difference. 8% for Coreg, 10% for Metoprolol. Absolute reduction in mortality over 5 years was 6%. We can extrapolate and say that Coreg extended survival by 1.4 years. Survival was 8 years on Coreg, 6.6 years on Metoprolol. Another way of looking at that is to say that 1 life per year would be saved for every 60 patients treated with Coreg. And that's similar to the ACE inhibitors. No significant difference in all-cause mortality and all-cause admission. The monthly cost is $117 for Coreg, $12 for Metoprolol. So there is an advantage, but it's an expensive advantage. So to summarize this, all patients with congestive heart failure without a contraindication, a medical condition that precludes beta blocker therapy, should be on a beta blocker. You feel better, your ejection fraction improves, your mortality is lowered. And I'm going to favor Coreg over Metoprolol when cost is not an issue. If your insurance company wants to pay 100%, I'm going to use the Cadillac, not the Buick. If the patient's struggling on Metoprolol, they clearly should be on the Coreg. The Coreg also has an antioxidant effect, and if your other doctors refuse to let you take antioxidants, then Coreg is sort of like an antioxidant. It's kind of like Metoprolol and coenzyme Q1. But everybody should be on a beta blocker. If I can get the job done on Metoprolol and save $90 a month, I will. If you're struggling with Metoprolol, or when cost is not an issue, we'll go with the Coreg. When the kidney is not getting enough blood because of heart failure, it elaborates a hormone called renin that causes the conversion of angiotensinogen into angiotensin, a weak vasoconstrictor. There's an enzyme in the serum called angiotensin converting enzyme that converts angiotensin 1, which is weak, into angiotensin 2, which is the most potent vasoconstrictor we have. If we gave you IV angiotensin 2, we could raise your blood pressure till you died of a stroke. It is a potent vasoconstrictor, and it's a good thing if your blood volume is low because you're bleeding to death, but it's a bad thing if you have congestive heart failure. So we're going to give you a drug, angiotensin converting enzyme inhibitors, to block this step. Now, all the studies have definitely shown benefits of angiotensin converting enzymes inhibitors in heart failure. It's a very, very good idea. They're also helpful in the patient with coronary disease because this is also an inflammatory mediator, not just a vasoconstrictor. We're going to look at 53 patients undergoing atherectomy. That's where you scoop out some plaque of the coronary artery, and we're going to measure the angiotensin converting enzyme levels within the plaque. And those with stable angina have low levels. Those with unstable angina, acute coronary syndromes, vulnerable plaque that ruptured, they have a lot more. So this enzyme is a bad actor, and we want to block it in patients with heart failure and patients with coronary disease. Now, we have these ACE inhibitors that work in the circulation. They're good for heart failure and for high blood pressure. We have some that are lipophilic or fat-soluble. They'll work their way into the artery wall, into the endothelial cells, and they'll block the generation of angiotensin 2 within the artery wall. Those are clearly the preferred drugs, because they will improve endothelial function. These drugs, quinapril and ramipril, they've been shown to decrease new-onset cardiovascular disease, diabetes, diabetic complications and events following a heart attack. In patients undergoing open heart surgery, going on quinapril reduces your 1-year event rate by 80%. They've been shown in angioplasty and stent patients to help prevent restenosis because they help you make nitric oxide. They blunt the progression of renal dysfunction. They're likely beneficial in angiogenesis, making new blood vessels. So a tissue-specific ACE inhibitor, quinapril or ramipril, is appropriate in all patients with coronary disease and congestive heart failure, and nobody would argue with that. Should we give you high doses or low doses? The drug companies would like us to give you high doses so they can sell more drugs. So they funded this study, high versus low dose ACE inhibitor in heart failure. Do you need a lot or just a little bit? With Digoxin, you need just a little bit. Some drugs you might want to push it to a higher level. Let's see if that applies to the ACE inhibitors. Just over 3,100 patients with heart failure, their ejection fraction is 23%. 89% had been on ACE inhibitors, and they were all able to tolerate ACE inhibitors. You randomized them to receive lisinopril, a ACE inhibitor that works only in the circulation, at a low dose, say 5 milligrams a day, or a high dose, 33 milligrams a day, and you follow them for 46 months with a double-blind format. and you find that there was an insignificant 8% reduction in mortality with high versus low dose. There were significant but not pronounced reductions in cardiovascular mortality, death or hospitalization, coronary disease hospitalization. So there was a benefit with high versus low dose, but it wasn't huge. Low dose costs $10 a month, high dose costs $40 a month. So we will start you at a low dose and work your way up, but I don't have to push you to the highest dose. I don't have to cause side effects or low blood pressure to give you a benefit, because the overall benefits of high dose are not much greater than low dose. So we will adjust that to meet your needs. So with ACE inhibitors, angiotensin-converting enzymes inhibitors, I'm going to treat all heart failure patients, all my patients with heart failure, unless there's a reason not to, with an ACE inhibitor. If some people cannot tolerate ACE inhibitors because they have a cough, then I use a drug called an ARB, or an angiotensin receptor blocker. But we prefer to use the ACE inhibitors, and I strongly want to use the fat-soluble lipophilic ones that will work in the circulation and get into the artery wall and protect your coronary arteries. I think that's very important. High versus low dose preferable, but not to the exclusion of other therapies. And in patients with prior heart attack and coronary disease in general, a lipophilic ACE inhibitor that gets into the endothelium is a good idea. Aldosterone blockade. So the kidney is not getting enough blood in the condition of heart failure. It releases this renin that converts angiotensin 1 to angiotensin 2. This angiotensin 2 is a bad guy. It's inflammatory, it's vasoconstrictive. It goes to the adrenal gland, which sits on top of the kidney, and tells the adrenal gland to make aldosterone. Aldosterone causes the kidney to retain fluid and does a lot of other things. Aldosterone is a hormone made in the adrenal gland in response to angiotensin 2 activity. So we're going to use these ACE inhibitors to block angiotensin 2, but that alone will not block the production of aldosterone, because in the doses we use, we don't block angiotensin 2 completely, and some of us, due to genetic weaknesses, make an awful lot more angiotensin 2 and aldosterone. The adrenal gland can also make aldosterone independent of this angiotensin 2 stimulus in response to poor blood flow or an electrolyte disturbance. So everybody with heart failure is making too much of this aldosterone, even if we give you the ACE inhibitors. So we have the problem with aldosterone. Now this aldosterone tells the kidney to retain sodium and waste potassium and magnesium. And that's bad, because that destabilizes the cardiac rhythm. It causes endothelial dysfunction. You stop making nitric oxide, your blood vessels constrict, your platelets get sticky. That's bad, can cause a heart attack. It causes the heart to become stiff, and it causes the heart to make more angiotensin receptors. Vicious circles, feedback loops are initiated. It causes the arteries to be stiff. It blocks the ability of the cells to take up adrenaline, so you have a sympathetic overdrive. It reduces heart rate variability, autonomic dysfunction, destabilizing the electrical activity of the heart, increasing the risk of arrhythmia, and it causes the heart muscles to fibrose. This is a real bad hormone for the cardiovascular system when it's pathologically upregulated. Now, if we take people with congestive heart failure and measure their aldosterone levels and divide them into terciles or thirds, those in the highest third do the worst. They're more likely to die. Survival's much better if you have a low aldosterone. Again, it's a real bad actor. So we're going to deal with it with a drug called spironolactone. Spironolactone is a competitive inhibitor of aldosterone. It's an anti-aldosterone. At 25 milligrams a day, it blocks the receptor, and at 50 milligrams a day, it blocks the synthesis. So with 50 milligrams a day, we're going to wipe out aldosterone. And spironolactone will right the wrongs carried out by aldosterone. Specifically, it'll restore endothelial function, which is key, and it'll retain magnesium, which is key. Spironolactone and endothelial function. Again, our short, intermediate, long-term outcome is related to the ability of these endothelial cells to make nitric oxide that provides the Teflon coating and vasodilatation and protects against clotting and cracking. So let's see if spironolactone can do that. 20 patients with heart failure, ejection fraction 24%. They're all on standard medical therapy. You're going to look at brachial artery reactivity before and after treating them with spironolactone. Now, the ability of an artery to dilate with nitroglycerin doesn't mean a whole lot. That's a drug effect. But if we look at flow-mediated vasodilatation, which is a measure of endothelial function, the ability of the endothelial cells to make nitric oxide, that's the key. It improves with spironolactone. Anything that improves endothelial function is good. If we're thinking about your outcome in congestive heart failure, endothelial function, the ability to make nitric oxide, is more important than your ejection fraction, your pump. So you would predict then that spironolactone would be helpful. Let's look at spironolactone and magnesium. Magnesium is useful in all cardiovascular conditions. If you're low on magnesium, you're in big trouble. The diuretics I give you wash out the magnesium. That's why we have side effects of diuretic therapy. 116 patients in Taiwan with heart failure, ejection fraction 35%. They're all on standard drug therapy. You do your baseline studies, randomize them to receive spironolactone or placebo, reevaluate at 6 months, double-blind protocols follow. Let's look at the effect on cardiac rhythm and autonomic tone. Heart rate was lower, 79 on drug therapy, 96 on placebo. So these hearts are pumping better, they're more efficient, and your heart rate is lower. You don't need as much blood and oxygen. That's a good sign. PVCs, premature ventricular contractions, and premature atrial contractions were blunted. There was less arrhythmia. One arrhythmia, atrial fibrillation or atrial tachycardia, we really don't want to see that in congestive heart failure. That sets you back maybe 30 to 40% in cardiac output. That occurred in 41% of those on placebo and 22% on spironolactone. So this diuretic, this weak diuretic that blocks aldosterone, is having a powerful effect on the autonomic function and the electrical integrity of the heart. It's having a powerful antiarrhythmic effect. Now why? It's not an antiarrhythmic drug. Why is spironolactone having such a powerful antiarrhythmic effect? If we look at the potassium level, spironolactone does retain potassium. In the placebo group, baseline it's 3.6, it's 4.1 spironolactone, 4.0 in placebo. That's not a big effect. If we just look at the magnesium level, it was 0.79 at baseline. It went up to 0.83 with spironolactone, 0.76 with placebo. If we look at intracellular magnesium, that went up the most. If we look at the rate at which magnesium will leave your cells, magnesium efflux, it was much greater with placebo than with spironolactone. Spironolactone is blocking aldosterone, which wants to kick magnesium out of the cells of the heart and the cells of the body, and allowing the magnesium to stay in our cells. It's not your blood magnesium that counts. That doesn't do anything. It's the magnesium in the cells of your body, the cells of your heart, that counts. Aldosterone kicks it out, spironolactone retains it. Thus you have this powerful antiarrhythmic effect. If we look at the change in heart rate, the higher your magnesium in the cells, the lower your heart rate and the fewer the arrhythmias. So this is a great drug with respect to keeping magnesium in your cells. If we look at the risk of atrial fibrillation versus serum magnesium, low, medium, or high, there's no protection. Because again, it's not the magnesium in the blood, but if we look at intracellular magnesium, those in the higher third, the upper tertile for magnesium in the cells, have a very, very low risk. So we want to get a lot of magnesium into you, this drug will help us do it. Ejection fraction rose 42% to 46% with magnesium. How far you could walk in 6 minutes improved, and there was a clinical improvement as well. So this drug improves endothelial function, it improves the electrical integrity of the heart, it gets magnesium in your cells. Let's see how it's going to do in a large study. The RALS study, randomized aldosterone evaluation study, 1,663 patients with class 3 or 4 heart failure. They're all a pretty sick group. Most of them are on all the standard drugs. Their ejection fraction 25%, decent kidney function, randomized to placebo or spironolactone, 25 milligrams a day. If they weren't better, you can go to 50. Otherwise, the same care. Their other drugs were not changed. multi-center, double-blind protocol. The study was halted at 2 years because there was a definite benefit with spironolactone. There was a 30% reduction in your risk of death. 46% with placebo, 35% with spironolactone. Death due to heart failure falls by 36%. Sudden death by 29% because it's stabilizing the electrical activity of the heart. Cardiovascular death falls 31%. Those are very powerful benefits for $52 a month. So spironolactone's a winner, it's inexpensive. But it's not patentable. So there won't be a lot of money to do research because no drug company can make money. So what the drug companies have to do is develop a new and improved and patentable spironolactone. So now we have eplerenone, which is an analog of spironolactone. We're going to take a study of 6,642 patients who are 3 to 14 days out from a heart attack. Their ejection fraction 33%. They all had heart failure or diabetes, reasonable kidney function, and they're on standard drug therapy. Randomized to placebo or eplerenone, otherwise same care, multi-center double-blind protocols followed. And there was a benefit. There was a 15% reduction in death. The death rate falls from 18% to 14%. There was a 20% reduction in death due to heart failure, 4% to 3%. That's not all that impressive. It was 20%. That was statistically significant, but that's not a really powerful benefit. And sudden death fell from 6% to 5%. So the FDA approved it. Here we have the RALS study, placebo versus spironolactone. Here we have the eplerenone study. The eplerenone patients obviously weren't as sick, but we're seeing similar reductions in death, or death due to progressive heart failure, sudden death, hospitalization for cardiac events. So spironolactone and eplerenone are pretty much interchangeable functionally. Total deaths falls by a third with both drugs. Side effects. The problem with spironolactone is it'll block the aldosterone receptor and the androgen receptor in men. So a side effect is gynecomastia, breast tissue enlargement in men. That's not okay for us. We don't like that. So that's a problem with this drug that does not occur with eplerenone. So the real advantage of eplerenone is you don't get gynecomastia in men. And that's really its only advantage. Another problem with these drugs is they tend to retain potassium. Most of the time we're worried about your potassium being too low, but if they give you too much of this drug, your potassium can go too high. That can be life-threatening. Now that doesn't happen overnight, and you're only going to get into trouble if I'm sloppy, which I tend not to be. But with these drugs, we have to watch your potassium because there's a 2 to 5% chance that your potassium could go too high. This is always something we can catch. So aldosterone blockade. This is a great idea whenever you have the opportunity in a patient with heart failure who's on standard drug therapy, utilize one of these two drugs. I have to watch your kidneys and your electrolytes closely, but if I do, you'll be okay. I'm going to favor spironolactone over eplerenone because of the cost. It's $125 a month for eplerenone, $32 a month for spironolactone. I'm going to favor eplerenone over spironolactone when cost is not an issue, but cost is always an issue in our society today. If you have gynecomastia, if a man has breast tissue enlargement, we're going to switch him over. Otherwise, I favor spironolactone. Cytokine blockade with metoprolol. Heart failure is associated with elaboration of inflammatory chemicals called cytokines. There's an alphabet soup of bad actors. Interleukin 6, C-reactive protein, tumor necrosis factor alpha. What causes this inflammatory response? Well, these neuroendocrine mediators. Angiotensin II causes the elaboration of the inflammatory process. The sympathetic nervous system, adrenaline and noradrenaline. Oxidative stress, inflammatory stress. And when you have congestive heart failure, you are infected. And your body responds as if you're infected. How is this occurring? Consider if fluid is building up behind the right heart and you have ankle swelling, edema, fluid is also building up within the bowel wall. The integrity of the bowel wall, the barrier, is compromised, and bacteria or bacterial cell wall will migrate from the colon into the circulation. And you will look infected. You'll be red, you might have a temperature, your white count may be high because you are auto-infecting yourself with bacteria from your colon. And the immune system will go on hyper alert. Your white count may go up, and you'll start making tumor necrosis factor as an antibacterial. You're going to respond to this chronic infection. Now, TNF, tumor necrosis factor, is part of our anti-infectious response. It was first discovered because it has an anti-cancer property. That's why it has the tumor necrosis factor name, but it's an immune mediator. And so your immune system is pathologically and chronically overstimulated when you have congestive heart failure. What are the consequences of this overexpressed TNF-alpha? It has a negative inotropic effect. We talked about digitalis causing the heart to squeeze better, a positive inotropic effect. This will tone down the heart, so it'll decrease pump function. Via a pathway called FASA-1, TNF causes the heart cells to commit suicide, called apoptosis. That's not good for you. It's for your heart cells to decide to die prematurely. It activates matrix metalloproteinases. These are degradative enzymes that want to make your plaques vulnerable. And it has a pro-atherosclerotic effect. So it's bad for your coronaries, it's bad for your heart. This TNF is a bad actor. Now, if we look at your TNF level from various studies, people who are normal have a TNF of 1. Those with class 4 heart failure have a TNF of 7. The worse your heart failure, the higher the TNF. That makes sense. If we look at your survival over time and look at your TNF level or your interleukin-6 level and look at your percentiles, those people with high TNFs or high interleukin-6 do worse, similar to those high aldosterone. The higher these inflammatory mediators are, the more whip damage to your heart, the more cell suicide, and the worse is your outlook. So, let's blow TNF away. Let's wipe it out, and then we can save our patients. The drug companies gave us a drug that blocks the TNF receptor, or an antibody that will bind it up. You're going to wipe TNF out of our physiology. The TNF functional level goes down to 0. Is this going to be helpful or not? This drug is used in the treatment of rheumatoid arthritis, because rheumatoid arthritis is also due to chronic overactivity of the immune system. And this drug works quite nicely in rheumatoid arthritis. So will this drug work in heart failure? Intuitively, you'd say, yeah, let's wipe out the TNF. So the study was done, and they saw that the group that got the drug did worse. They were more likely to die of heart failure and to have heart attacks, which was not at all unexpected. So the cardiologists who write the journal articles and the editorials, they'll say there's no role in medicine for TNF blockade. But what they meant to say is there's no role in medicine for TNF blockade with patentable drugs. Because there's an old drug called pentoxifylline, trade name's Trental, that was used in the past for intermittent claudication, poor blood flow to the legs. It turns out that Trental will blunt the transcription of TNF, that is the reading of the DNA, when it's overactive. So, you need some TNF. When you wipe it out completely, Mother Nature didn't give us TNF just to kill us. We're supposed to have low levels, and that protects our arteries. It kills us when the levels are too high. So we give you a drug to wipe it out completely, we take away the bad and the good. If we modulate its production with pentoxifylline, we blunt the TNF, we don't wipe it out. So you get rid of the bad without getting rid of the good. So here's some studies. Pentoxifylline in ischemic cardiomyopathy, people with advanced heart failure due to coronary disease. They're all on standard drug therapy. Their ejection fraction below 40%. After 3 months of observation, randomized to placebo 3 times a day or pentoxifamine 400 milligrams 3 times a day, you reevaluate at 6 months. Now, 5 people died, 4 in the placebo group. Double-blind protocol followed. The C-reactive protein, an inflammatory mediator, went up with placebo therapy. It fell with pentoxifamine. The TNF level fell. That fast APO1, which causes the cell suicide, fell. BNP, remember, that's the lab marker of the severity of heart failure. It rose with placebo therapy. It fell dramatically from 267 to 46 with pentoxifamine. Ejection fraction rose from 28 to 37 with drug therapy. It did not rise with placebo therapy. 10 of the 19 patients on pentoxifamine increased their ejection fraction by 10 points. Wow, by blocking this inflammatory whip. Treadmill time increased. New York Heart Association functional class fell. It improved. You want a low functional class. Class 4 is symptoms at rest. Class 1 is asymptomatic. So their ejection fraction rose, their biochemistry improved, and their functional status improved. Pentoxifamine and dilated cardiomyopathy, these are people without coronary disease and weak hearts. 39 patients, none with coronary disease. They're all on standard drug therapy. You randomize them to placebo or pentoxifamine, reevaluate at 6 months. The TNF levels fell only slightly, but the fast APO1 fell a lot. Ejection fraction rose, treadmill time improved, a beneficial effect, functional class improved. So, pentoxifamine is of great value in congestive heart failure, in ischemic cardiomyopathy, that's heart failure due to coronary disease, in dilated cardiomyopathy, that's non-coronary heart disease, hypertensive and postpartum cardiomyopathy, that's heart failure following birth of a baby. Cost is $18 a month. So I'm going to treat all my patients with pentoxifamine. The questions I have are, do we even need to measure the TNF levels? In these studies, the people had TNF levels within the normal range, they still benefited. Necessity of prior concomitant drug therapy. So there's some questions here, but this is a very inexpensive drug which is useful in all patients with congestive heart failure. Okay, let's talk about statin therapy in congestive heart failure. Many of you are taking statin drugs to lower your cholesterol. HMG-CoA reductase inhibitors. How do they work? We make cholesterol in our body from 2 carbon fragments that we get from fat and sugar. And this enzyme, HMG-CoA reductase inhibitor, HMG-CoA reductase is involved in one of the steps, and the statin drugs block this. So they're not blocking the production of cholesterol, they're blocking one of the pathways in the biochemical assembly line that makes cholesterol. They're also blocking the generation of isoprenoids, farnesyl and geranyl pyrophosphate. These are involved in intracellular signaling. They will bind to proteins that stimulate inflammatory phenomena and generate free radicals and upregulate production of angiotensin II. So basically, when you are taking a statin, it's working not by lowering your cholesterol. I don't think statins work by lowering cholesterol. They work by blocking farnesylation and geranyl-geranylation of the signaling proteins. So if your doctor recommends that you take a statin, say, "Doctor, why do you want me to take a statin?" "Well, to lower your cholesterol." And you go, "No, doctor, that's not right. Dr. Roberts said that you should take a statin to block geranyl-geranylation of Rho, RAC, ROS, and laminin." And that's really how it's working, because this is blocking an inflammatory cascade. These signaling mechanisms cause the apoptosis, the cells to commit suicide, degradation of the plaque wall, coagulation, free radical stress. That's how the statins are working. The fact that your cholesterol is low is just a marker that the statins are there. Now, there is some role in lowering cholesterol, but that's not the key. It's the anti-inflammatory effect. So let's take a look at will statins help in heart failure. Just over 1,100 patients with heart failure, some due to coronary disease, some due to cardiomyopathy, class 3 to 4 symptoms despite drug therapy, ejection fraction 21%. Now what we're going to look at here is retrospective analysis of the PRAISE study, which was a study of calcium blockers. At the discretion of the physician, the patients involved in the study could be treated with a statin, and 12% did. And those that were treated with a statin were more likely to have coronary disease than normal arteries, more likely to have high cholesterol. This was not a randomized double-blind study, but they followed them for 15 months to see would the statin therapy have any effect. Now, will statin therapy in heart failure intuitively seems to me to be a very dumb idea. Safety and efficacy studies of the statins were never done in patients with pump dysfunction or heart failure. Statins, while they're blocking the production of cholesterol, are blocking the production of coenzyme Q. And you have to have CoQ to make energy. And we'll talk about CoQ next week. And people with borderline hearts, poor pumps, if you give them a statin, you can produce frank congestive heart failure because you take away their CoQ. That's well described in the literature. So why would we want to give a patient a statin? I mean, it depletes CoQ. It could cause pump dysfunction. And it's interesting that the outcome of patients with heart failure is inversely related to their cholesterol. Individuals with low cholesterols are more likely to die than people with high cholesterol. So if you have congestive heart failure, a high cholesterol is protective. Why? Because A, it's an antioxidant. B, it will bind up bacterial cell wall products. So cholesterol is actually protective in heart failure. So we're going to give you a statin drug to lower your cholesterol and to lower your coenzyme Q. This sounds like a crazy idea. But when they looked at the patients, they did better. There was a 62% reduction in death rate. Here's survival was better with statins. 12 versus 31 deaths per 100 patient years. 1 fewer death for every 5 patients treated. That's puzzling. 62% reduction in mortality, 57% reduction in sudden death, 70% reduction in pump failure. And this relationship in people not on statins, a high cholesterol is protective, that was abolished with statin therapy. So lowering cholesterol with statins seemed to be a good idea. Now, when we're treating patients with cardiovascular disease, we want to improve endothelial function. We want to encourage the endothelial cells that line our arteries to convert arginine to nitric oxide. That's really the key to survival. Now, here's an endothelial cell that lines our arteries. There are invaginations in the cell membrane called caveoli, and that's where all the biochemistry is occurring. If you have a normal cell wall that doesn't have too much cholesterol, that doesn't have a lot of trans fats or saturated fats, that has fish oils and phosphorylcholines, that cell membrane's working really well. You can get arginine in and nitric oxide out, that's working quite well. But if it's stuffed full of cholesterol and trans fats, you can't get the arginine and the nitric oxide out. So if you got too much cholesterol in the cell membrane, that's going to compromise your ability to make nitric oxide, and that's bad. If you're not making a lot of nitric oxide, you're going to start making free radicals. You're going to make superoxide a bad guy. And statins blunt that. By blocking granulation of RAC, RO, ROS, and laminin, they will downregulate some of the enzymes that make free radicals. We're very interested in antioxidant therapy in coronary disease and heart failure. Statins aren't classically antioxidants, but they block the generation of free radicals, so they act like they're antioxidants. So this is the biochemical explanation as to how statins may be helpful in congestive heart failure. Statins do have a lot of benefits. They block oxidation. They lower oxidized cholesterol. They improve endothelial function. They block inflammation. They block white cell adhesion to the vessel wall. They downregulate the immune system. You know, cardiovascular disease is an autoimmune disease. Our immune system becomes confused
and it's fighting bacteria. It will get confused and fight our cells. We can find clones of lymph cells in activated invulnerable plaque. There's many beneficial effects of statins, and this is really how statins work. Not by lowering cholesterol, but by improving our biochemistry, blocking oxidation, blocking inflammation. So is it going to work in congestive heart failure? We've discussed the biochemical rationale. Let's see if it's really going to work in a randomized double-blind study. Here we take 63 patients with dilated cardiomyopathy, not due to coronary disease. So there was no coronary disease to treat with the statin. They all were symptomatic. Their ejection fraction is 33%. They're all on as much drug therapy as they can tolerate. Baseline assessment, randomized to receive simvastatin, 10 milligrams a day, or placebo, reevaluate at 14 weeks. Double-blind protocols follow. TNF fell with statin therapy, not with placebo. Endothelial function improved. Interleukin-6, another bad actor, fell. BNP, the marker of the severity of heart failure, fell. Biochemical benefits. Ejection fraction rose from 34 to 41%, functional class improved. So low dose statin therapy, not enough to wipe out CoQ, but enough to tone down the inflammation, was a great benefit in congestive heart failure. So statin therapy does make sense. Simvastatin, 10 milligrams a day, costs $55 a month. We'll talk about CoQ next week, but if we're going to give you a statin, it's crazy not to give you coenzyme Q. This way you can get the good without the bad. Question is the optimal dose. It appears that a small dose, a little dab will get the job done, similar to the digoxin. What are some of the long-term side effects of immune system suppression? There are nutritional agents that don't poison the HMG-CoA reductase enzyme, but they downregulate its production, such as Reggie's rice extract and polycosanol. Will they have the same effects? Based on the literature today, yes, they will. So blocking the generation of those inflammatory mediators with statins, Reggie's rice, or polycosanol makes a lot of sense. Enhanced external counterpulsation. We've been doing that for a decade. We apply pneumatic cuffs to the patient's lower extremity. We inflate and deflate in conjunction with the cardiac cycle. And what we're going to do, we generate a retrograde pressure wave. We milk oxygenated blood from the lower extremity and jam it into the coronary arteries. So we create a retrograde pressure wave in the aorta at the level of the finger and in the coronary arteries. Then we lower the systolic blood pressure so the heart is ejecting into a vacuum. We call that afterload reduction. During the 1 hour treatment, the heart is rested and it's hyperoxygenated. And we do this Monday through Friday for 7 weeks, and we wind up growing natural bypasses, collaterals, with this technique. And if we do that, you can walk farther on the treadmill, and we can improve or normalize your nuclear scans. We have an antioxidant effect. We lower malondialdehyde, which is a marker of free radical stress. We improve endothelial function. We double your nitric oxide level. We elaborate angiogenic growth factors, a lot of favorable biochemistry. And the shearing stress of the retrograde pressure wave encourages the endothelial cells lining our arteries to convert arginine to nitric oxide. And anything that improves nitric oxide is of great value to the patient with coronary disease and, part of tonight's discussion, of value to the patient with congestive heart failure. I've been doing this for 10 years. I've treated about 900 people. I treated 181 patients during my first 3 years, and this is New York Heart Association functional class, and you want a low number. And my patients with native disease, prior bypass, prior angioplasty or stent, prior bypass, and angioplasty or stent all improved, and I kept my patients out of the hospital. Over the first 3 years, I treated 181 patients. Over the 2 years before ECP, 81% had an event. The 2 years post-ECP, only 22% had an event. So it really works well in coronary artery disease, particularly inoperable or recurrent coronary disease. Will it help with heart failure? The physiologic effects of external counterpulsation pertinent to heart failure are: we have an antioxidant effect, we improve endothelial function, systolic function improves, your ejection fraction improves, diastolic function improves, the heart is less stiff, kidney function improves, So the kidney does a better job of excreting sodium and chloride in water. So physiologically, it would make sense that ECP would help. Will it actually help clinically? Let's take a look. This study was done when I was in high school using the old-fashioned external counterpulsation devices that were a water-filled leg bag as opposed to the modern-day sequential pneumatic device. But this study looked at 258 patients presenting to 12 university hospitals in the United States with a heart attack complicated by significant congestive heart failure. They had crackles halfway up their lung bases, a sick group. They were randomized to standard therapy or standard therapy plus as much external counterpulsation as they could get on their first hospital day. Hospital mortality in the control group with drug therapy alone was 15%. Those that got at least 3 hours of external counterpulsation on their first hospital day, it was 7%. Those that got 4 more hours, it was 6%. A significant reduction in mortality. Mortality due to pump function, pump failure fell from 14% to 6%. Progression to advanced heart failure fell from 15% to 7%. Recurrent chest pain was blunted. More patients were discharged free of heart failure. And with this, the FDA approved external counterpulsation for the treatment of heart failure and the treatment of heart failure compromising a heart attack. And this was with the old-fashioned, inefficient hydraulic system. What will be the effect using our current sequential pneumatic system? Here's a study of 26 patients with stable heart failure, ejection fraction 23%, all on maximal medical therapy. In 19, they had heart failure due to coronary disease, prior heart attacks. In 7, they had cardiomyopathy, heart failure due to a weak heart muscle. They had a 2-week baseline period, do labs and stress tests. Then they get the standard 35 hours of ECP over 7 weeks. Then you reevaluate 1 week and 6 months post-ECP. Treadmill time increased by 21% by the end of ECP, and it remained 16% above baseline 6 months later. Peak oxygen uptake, which is the best measure of your aerobic fitness and cardiovascular health, rose 7% after ECP, and then it improved further, 27% 6 months later. The change in peak oxygen uptake from baseline was the same in the people with coronary disease or the non-coronary cardiomyopathy. Same thing with improvement in quality of life. Another study, outcomes and ejection fraction in patients with angina and heart failure were treated with ECP. 130 consecutive patients with advanced angina. Most were having pain at rest. They were inoperable and they had heart failure, a real sick group of people. Their ejection fraction was 33%. You're going to look at their functional status and ejection fraction, their event rate over the preceding year, treat them with 7 weeks of ECP, and reevaluate. Follow them for 1 year. Mortality was 5%. 6 of the 7 deaths were those with class 4 heart failure, which is what you would expect. Of the survivors, the ejection fraction rose by 24%, from 33 to 41%. New York Heart Association functional class improved by 28%. Hospitalizations per year fell by 72%, from 1.8 hospitalizations per patient to 0.5. Powerful benefit there, quite cost effective. So external counterpulsation is phenomenal in recurrent or inoperable coronary disease. We've treated 900 patients. It's also quite helpful as a device modality in congestive heart failure. Here's another device modality for congestive heart failure, far infrared sauna. You can buy a far infrared sauna for about $400. It's a little box and you can fold it up, and it has these ceramic plates that you heat, that you apply electricity to, and they heat up, but it's not real hot like a real sauna, and the plates will radiate energy into you. It's basically the rays of the sun that cause you to sweat, but not a sunburn. So it's basically sweat therapy, and you'll start sweating a lot. When you're young and you would exercise, you would sweat profusely. As we age, our ability to sweat falls off. Some of it's because we're using aluminum-containing antiperspirants that poison our sweat glands, but just with aging, we don't sweat, and we detox in our sweat. So if we don't sweat, we can't get rid of toxins. So this is a sweating detox therapy. Let's see if it's going to work in heart failure. 30 patients with advanced heart failure and a lot of extra heartbeats. Their heart was electrically unstable. They had at least 200 PVCs for 24 hours. And you're going to treat them Monday through Friday for 2 weeks. Half get 15 minutes of far-infrared sauna at 60 degrees, followed by 30 minutes bed rest under blankets. The placebo therapy was 45 minutes of bed rest. At the end of the study, the patients randomized to sauna were having fewer PVCs for 24 hours, just over 1,000 versus over 2,400. So the sweat therapy, getting rid of toxins, had an antiarrhythmic effect. Heart rate variability. Heart rate variability shows that your autonomic nervous system, your sympathetic and parasympathetic, is in balance. You want a high degree of heart rate variability. That is associated with a very good prognosis. Heart rate variability improved with sauna therapy. The BNP, that marker of heart failure that falls with ECP, that falls with statin therapy, that falls with pentoxylene therapy, it fell. It was 293 with sauna therapy versus 443 with control. Another study, sauna, endothelial function, and heart failure. 20 patients with heart failure, 16 had dilated cardiomyopathy, 4 had ischemic or coronary cardiomyopathy. Ejection fraction 38%. They're all on standard drug therapy. The active treatment was 15 minutes of far-infrared sauna at 60 degrees, followed by 30 minutes of bed rest under blankets, Monday through Friday for 2 weeks. The control group, 10 matched patients observed room temperature. Functional class did not change in the control group. 5 were in class 2, 5 were in class 3 before and after. Functional class improved in the sauna group. 1 moved into class 1. They went from 10 to 5 in class 3. So there was a functional improvement with sauna therapy. Flow-mediated vasodilatation, endothelial function, which is so critical, improved with sauna therapy, not with controls. BNP fell, and there was a correlation as the decrease in BNP was directly related to the improvement of flow-mediated vasodilatation. So you're improving endothelial function, you're vasodilating, you're de-stressing the heart failure improves, the BNP falls, and your autonomic nervous system is benefiting. 17 of the 20 were improved at 2 weeks, and those that improved their flow-mediated vasodilatation the most. So it's improving endothelial function a lot. Sauna, ghrelin, appetite loss, and heart failure. Ghrelin is an interesting hormone. It's made in the stomach. It's elevated in patients with heart failure. If you give it IV to patients with heart failure, their cardiac function improves. It is a compensatory response to heart failure to raise ghrelin. So your stomach is helping you compensate for your heart failure by releasing ghrelin. 24 patients with heart failure, randomize them to 15 minutes of far-infrared sauna at 60 degrees, followed by 30 minutes of bed rest under blankets or no active therapy. They found that the observational group didn't get better. Appetite loss improved in 85% of the sauna-treated patients. Patients with heart failure are inflamed, they lose their appetite, and then they lose their muscle mass and they waste away. Far-infrared sauna blocked that, probably by elaborating ghrelin, which allowed them to maintain a normal appetite and maintain their muscle mass. Ghrelin levels rose with sauna therapy. Growth hormone levels went up. If you have advanced heart failure and I give you subcutaneous growth hormone, you'll get better. That's been well worked out. It just costs $20,000 a year. Another way would be to buy a far-infrared sauna for $400 and treat yourself. Noradrenaline, that's one of the bad guys, the adrenaline whips, it fell. So far-infrared sauna has a very powerful effect on the hormonal status. You raise growth hormone, you lower noradrenaline. Ejection fraction rose from 31 to 36%, BNP fell. Cardiac resynchronization therapy, dual chamber pacing. Consider you've got a dilated pump heart. And as a consequence of your heart failure and cardiomyopathy, you may have a conduction disturbance. You have bundle branch block. And what that means is one wall of the heart will activate a split second before another wall. So the heart, the walls of the heart are not moving in synchrony. They're kind of fighting one another. If you've had a heart attack and you have an area of scar here, that will tether the adjacent segments of normal heart so they don't move inward at the same time. So you have a mechanical disadvantage above and beyond the problem with the pumping. So the idea of dual chamber pacing is you put a pacing wire into the right ventricle, and you could put a pacing wire into the left heart by opening up the chest. A better way is to put another pacing wire in the right heart and then put it into the vein that drains the left heart. So you can pace the right heart and the left heart independently. And you can time this and synchronize it so if one wall is moving in late, you can compensate. Now all of a sudden, all the walls are moving in together and getting a better mechanical efficiency. And in theory, this should improve pump function. Let's see if this works in practice. These are pressure volume loops. You want to be able to generate a lot of pressure at a lower volume. And if you just pace the right heart, nothing happens. But if you have a biventricular pacemaker or a right ventricular and left ventricular free wall pacer, you do get this mechanical advantage back in your favor. And in several studies, different device manufacturers have made these products, and they've done studies to try to demonstrate benefit. And the end diastolic and the end systolic volumes of the heart will decrease. The heart will become smaller. The ejection fraction will rise between 3 and 6%. New York Heart Association functional class improves in 16 to 30% of the patients. Patients can walk farther. So your heart is smaller, it pumps better, and your functional status improves. Now, if we're going to put in this dual chamber pacemaker, why not put in a defibrillator at the same time? I mean, you're going to put the pacemaker device in your armpit, you're going to put the wires in, why not add a defibrillator feature? It doesn't add to the risk of the implantation, and it makes sense because many of you with advanced congestive heart failure, your mode of death is going to be an arrhythmia. We can give you enough diuretics to get rid of the fluid, but you might have an electrically unstable heart and you'll die of an arrhythmia. Well, if we have a defibrillator in you, you can't die of an arrhythmia. So does this make sense to do this? Intuitively it makes sense, but the device manufacturers had to prove it to Medicare to get Medicare coverage. So they did this study of 1,500 patients who were in normal rhythm and they had heart failure. Their ejection fraction 20%. They'd all had at least one hospitalization, and they had a conduction delay. They had a bundle branch block such that they did have the dyssynchrony problem. Putting a dual chamber pacemaker in when your heart is functioning synchronously wouldn't give you any advantage. So these were people that had the potential to improve, to get synchrony back. And there was no other reason to put in a pacing device or a defibrillator, and they're all on as much drug therapy as they can tolerate. So you randomize them to ongoing drug therapy and the dual chamber pacemaker, or drug therapy with the dual chamber pacemaker and the defibrillator, and you're going to follow them for events. And what you find is the systolic blood pressure fell with drug therapy. Normally we want to see a low blood pressure, but these are people, their blood pressure is only 90 to 100 from all the drugs they're on, and that low blood pressure causes fatigue. The blood pressure increased slightly with the pacemaker because you get better pump function. So that was a clinical advantage. Increasing walking distance. At 3 months and at 6 months, those on drug therapy didn't improve. Those that got the pacemaker with or without the defibrillator could walk farther. Improvement in the Minnesota heart failure score was minimal with ongoing drug therapy. The pacing devices improved functional status. At 1 year, if we look at death or hospitalization, any cause, 68% with drug therapy, 56% with the pacemaker, so there's a 20% reduction in death or hospitalization of all causes. If we look at death only, there's a 12%, 25 and 36% reduction. So it keeps you out of the hospital and decreases all-cause mortality. If we look at death or hospitalization or due to cardiovascular disease or for heart failure, there's a 25 to 34% risk reduction. Now these are very, very sick people. I mean, with drug therapy, the death rate is 60%. With the pacemakers, it's 45%. It's no panacea, but there was still a 25 to 28% risk reduction. And thus Medicare and the insurance companies now covers placement of the dual chamber pacemakers with defibrillators in people with advanced heart failure. Many of my patients have benefited from this. It works quite nicely. It has really helped some of my patients out when they have advanced heart failure and they're failing despite everything I know. So it is an effective therapy. Magnetic molecular energizer therapy, we're going to spend 2 hours on that in about a month. This is a 10,000 pound electromagnet. It's generating a very powerful 5,000 Gauss uniform magnetic field. We emit the field above you. It runs through your body, through your heart. It's collected in the inferior pole and returns in a C loop. So we have a very, very powerful static magnetic field that we run through your heart. And what this does, it accelerates your electrons. The magnetic field increases the rate at which your active valence electrons orbit the nucleus. And all of your biochemistry involves the sharing or exchange of an electron from atom A to atom B. So we're going to speed up all useful biochemistry in the heart or the organ we treat. We're going to make a lot of ATP, and that's the source of energy that the heart utilizes. We stimulate the electron transport chain, which makes ATP. We stimulate the enzymes that use ATP. We want you to make a lot of ATP. We want you to use it for the heart to contract, to relax, and to repair itself. And this is very important because the higher the ATP level in your heart or in any cell in your body, the better will all your biochemistry function. You need a high level of ATP to drive forward all useful chemical reactions. No matter what the problem is, part of the solution is going to be to make energy. And we can generate a lot of energy in the heart when we treat you with MME. There's a number of beneficial effects of a properly oriented magnetic field on our physiology. And we'll talk about that more in one of our later procedures or lectures. So let's look at cardiomyopathy and heart failure. Why should MME help? Well, we do improve endothelial function. We make nitric oxide, so forward blood flow will improve. The filling pressures fall. The magnetic field blocks the adrenaline whip, and it blocks aldosterone. It provides an alkaline environment, it oxygenates, it has an antioxidant effect. ATP generation utilization increase. Heavy metal detoxification. People that have dilated cardiomyopathy, a weak punk heart, not due to coronary disease, if we biopsy those hearts, we find that they have 22,000 times as much mercury in their heart as do normal people, 12,000 times as much antimony, 250 times as much arsenic. The greater the content of the metals, the worse their heart pumping function, the more complicated their arrhythmias. So dilated cardiomyopathy in most situations is metal toxicity. It's probably not that you've been exposed to more metal than the next person. It's probably that you have a genetic predisposition, kind of like the kids with autism. Any mercury blows away their nervous system. I think of cardiomyopathy as autism of the heart. And I want to get the metals out, and we know that we can get the metals out of the heart much more readily if we apply a powerful magnetic field to the heart along with a metal binding agent. And so we make ATP, we promote detoxification. All of our organs have stem cells that are dividing slowly to replace the cells that are lost. We don't have any cells in our body that are more than 10 years old. And we feel the magnetic field causes our stem cells to proliferate more rapidly. We do not alter our DNA, but we can alter the reading, the transcription of the DNA in a favorable fashion. More on this in a few weeks. But here's what we can do with the technique. Here's a man who's a runner. He used to run marathons, and he presents with atrial fibrillation, and a dilated heart for no good reason, and all the 4 chambers are dilated and his heart's kind of punk, and his mitral valve is very, very leaky. This blue flame here is leakage beneath the mitral valve. So we treated him with MME and mercury detoxification. You can see this heart is squeezing a lot better, and the mitral regurgitation decreased. I don't know if we repaired the valve or by shrinking the heart we caused the valve to function better, but the man got a lot better, and now he's back to running again, which I think is kind of neat. Here's another patient who had high blood pressure, cadmium and lead toxicity, and heart failure. The heart chambers are enlarged, the heart's pumped, there's a lot of regurgitation beneath the mitral valve. After we treated her, her heart looked a lot better, and the mitral regurgitation decreased. And we have many, many cases of cardiomyopathy that we treated successfully with magnetic molecular energizer therapy. So it's another useful device modality to treat congestive heart failure. So when we're treating congestive heart failure, our therapies are based upon our understanding of the pathophysiology of congestive heart failure. Next week, we'll talk about the nutritional approaches, coenzyme Q, carnitine, ribose, magnesium, thiamine, fish oil, testosterone, vitamin D. We're conducting a study of EDTA chelation therapy, which is a metal detoxification therapy, in improving outcome in patients with prior heart attack. We'll talk about that. Tonight we talked about the classic approach that didn't work so well, the approach that we used when I was an intern, digoxin and diuretics, and then we moved into modern day drug therapy, ACE inhibitors, aldosterone blockers, beta blockers, metoprolol, statins, and device therapies, external counterpulsation, far-infrared sauna, dual chamber pacing, and MME. When I was an intern, the 1-year mortality for heart failure was 52%. We had only digoxin and diuretics. We add in the ACE inhibitors, we get to 36%. We added spironolactone, 18%. Beta blockers, 12%. So in 25 years, we've gone from a 1-year mortality of 52% to 12% utilizing drug therapy. Our therapies are based upon our understanding of the causes and consequences of coronary disease and heart failure. And my approach, I will use diuretics judiciously to control your symptoms. I want to get rid of your edema and your shortness of breath with diuretics, but I'm going to be careful not to wash out your thiamine, your potassium, and your magnesium, because if I wash out your potassium and you die of an arrhythmia, I have not done a good job. I'll use tissue-specific ACE inhibitors, but I'll watch to make sure I don't lower your blood pressure too much or compromise your kidney. And I'm not going to, I will increase the dose, but I want to leave room for spironolactone, which improves endothelial function, retains magnesium within the cells, and has an antiarrhythmic effect and improves outcome. I'll use a beta blocker, Carvedilol or Metoprolol. If you're struggling on Metoprolol, I'll switch to Coreg. Otherwise, I'm going to use Metoprolol because it's much less expensive. Pentoxifylline is useful in all patients with all forms of heart failure, and there's a role for low-dose statin therapy. In selected patients, you might benefit from external counterpulsation or dual-chamber pacemaker implantation. All patients, I believe, benefit dramatically from magnetic molecular energizer therapy. All my patients are advised to take a 6-a-day vitamin and mineral supplement. We're going to put you on a program of essential fatty acids, bioenergetic support with CoQ, carnitine, ribose, and magnesium. Taurine, we'll talk about that, improves endothelial function, helps retain magnesium. Vitamin D, if the levels are low, testosterone in men, and detoxification, because everybody with heart failure is toxic, particularly if you have a dilated cardiomyopathy, which I believe is due almost entirely to heavy metal overload. So we need a detoxification program, chelation, homeopathy, the ionator foot bath, far-infrared sauna, or MME. And that's all I have to say tonight about the use of drugs and devices to improve patient outcome in congestive heart failure and following heart attack. This information is available on the website, heartfixer.com, and much of this is available in our book, Reverse Heart Disease Now. Thank you very much for your attention.